Our next presentation, Dr. Brett Morris, one of our first-year residents, is going to be talking about beta blockers and cocaine-related acute chest pain. And having just taken my critical care boards, I can tell you that this is definitely a topic that was discussed in my board reviews. So I'm interested to hear what you have to say.
Good afternoon. My name is Brett Morris. I'm a preliminary internal medicine resident here. We'll be talking about beta blockers and cocaine-related acute chest pain today. I'm a co-investigator on an AstraZeneca-sponsored clinical trial that receives pharmaceutical support with these two drugs, tremelimumab and durvalumab, which are PD-L1 inhibitors and CTLA inhibitors. We will not be talking about those today. We will be talking about the cocaine epidemic. So cocaine, it's estimated that 20 million people in the world are using cocaine. In the United States, it's estimated that 1.5% of the population was using cocaine in the year 2014. And this data is a little outdated now, but 40.3% of hospital ED drug-related visits at the turn of the decade were cocaine-related, which accounted for the majority of those visits. And abuse is associated with dysrhythmias, acute coronary syndrome, stroke, heart failure, and renal failure. The rate of MI is about 6% in patients with cocaine-associated chest pain. So how does cocaine affect the heart, and how does it elicit these effects? So looking at the physiology of cocaine, as the Chappelle Show taught us, cocaine is one heck of a drug. Besides making Rick James slap Charlie Murphy and destroy Eddie Murphy's couch, it increases central and peripheral levels of epinephrine, norepinephrine, and dopamine by blocking reuptake transporters. And it leads, therefore, to prolonged alpha and beta stimulation. More specifically, cocaine can cause an acute increase in heart rate, systolic blood pressure, and mean arterial pressure. And how it does this is best illustrated on this graphic, where you can see that leading to coronary vasoconstriction, we have decreased myocardial oxygen delivery. We also have an acute increase in heart rate and blood pressure, leading again to increased myocardial oxygen demand. This also increases shear stress, leading to plaque rupture and potential for thrombosis. Long term, you can have inflammation leading to atherosclerosis and decreased elasticity. And then you have activation of platelets and endothelial dysfunction, leading to a transient hypercoagulable state with increased risk for thrombosis. This has led to the dogma that many of us probably remember from medical school, that cocaine-associated chest pain is an absolute contraindication to beta blockers due to this so-called unopposed alpha effect. Beta blockade can potentially lead to alpha stimulation, leave alpha stimulation unopposed, resulting in pronounced systemic and coronary vasoconstriction. And as I said, the long-standing teaching being to avoid beta blockers. But let's take a look at the evidence. So there's evidence on both sides of this question. Against beta blockers in the setting of acute cocaine intoxication, we have multiple animal studies, 2 prospective randomized control trials from the 90s, 1 prospective cohort study, and multiple case reports. In support, or at least showing no adverse events with the use of beta blockers, we have a prospective randomized control trial, multiple retrospective studies, and then a meta-analysis review. The animal studies I won't spend too much time on. If you read them, there's a lot of flaws in the animal studies. They were done in rats, dogs, and non-human primates, but most of the studies used non-pharmacological dosing of beta blockers, and they targeted a systemic level of cocaine in these animals for the LD50, and then were surprised when half of the animals died. But all of these studies concluded that there's deleterious effect of propranolol and a neutral effect of labetalol. But the first human studies were completed in 1990 and 1993 at the University of Texas Southwestern. They were randomized control studies. They took 15 patients in each study. The first in 90 looked at propranolol. The second in 93 looked at labetalol. So they took patients who were undergoing coronary catheterization for chest pain, consented them, and then had them do 2 mg per kg of intranasal cocaine, and then delivered the beta blocker or saline solution, either intracoronary for propranolol or IV for labetalol. And Dr. Fitzgibbons is here in the audience today, and I can only imagine that this was an easy, expedited review for the IRB process. It was a different time in research. So looking at that first study in 1990, propranolol in the setting of acute cocaine intoxication. So this graphic is a little complicated, but this is the change in baseline after administration of cocaine. And then on the far side, after intracoronary propranolol delivery, it's the change from the new baseline from cocaine on the top and the change from the original baseline during catheterization. What they found was that cocaine, not surprisingly, elevated systolic arterial pressure, mean arterial pressure, and coronary vascular resistance. And it had led to decreased coronary blood flow and decreased size of the mid and distal LAD diameter. Administration of propranolol, which is a non-selective beta-1, beta-2 blocker, further diminished coronary blood flow while lowering systolic arterial pressure and increasing coronary vascular resistance. From this study, the authors said that using a non-selective beta-1, beta-2 antagonist was contraindicated in these patients, which I think we could agree upon. In '93, they went on to then study labetalol, same study design. And again, in the setting of cocaine abuse, these patients had an increase in their mean arterial pressure as well as their a decrease in their coronary arterial area. However, while administration of IV labetalol decreased mean arterial pressure, it did not have any effect either widening or further narrowing the coronary arterial area, suggesting that there was not an unopposed alpha effect in these patients. And this is likely the difference between using non-selective beta-1, beta-2 blockade of propranolol versus the alpha-1, beta-1, and beta-2 blockade of labetalol. In between these two studies, there was a prospective cohort study that looked at esmolol, so beta-1 selective antagonist. They took 7 patients with cocaine toxicity, treated them with esmolol. They found that it decreased the heart rate and had an inconsistent effect on blood pressure. So there was 1 treatment failure with esmolol requiring nifedipine for control of blood pressure, and then 3 adverse events. 1 patient had a large rise in their systolic and diastolic blood pressure. Interestingly, the authors decided to manage that with labetalol. 1 patient experienced hypotension, requiring the use of phenylephrine. And then the 3rd patient had resolution of their symptoms, but then became very lethargic and started vomiting and required intubation. From this, the authors concluded they would not recommend esmolol for cocaine-related chest pain. And really, that's about it. So the defense sort of rests there on avoiding beta blockers in the setting of cocaine-associated chest pain. So what's the evidence on the other side? There was 1 randomized prospective study where they compared patients who presented to the emergency department with acute coronary syndrome, 2 of 3 symptoms, chest pain, EKG, ST segment changes, or a troponin elevation, and importantly, a urine toxicology positive for cocaine. They did standard of care ACS management for these patients and started them on either labetalol 200 milligrams BID or extended release diltiazem 240 milligrams daily. They then looked at outcomes 48 hours later in these patients. They found that there was no difference in baseline hemodynamics or response in heart rate or blood pressure. There were no adverse events in either group. And surprisingly, and they don't really have a great explanation for this, but the beta blocker group had a decrease in inflammatory markers compared to the diltiazem group. So here's just looking at, again, with systolic pressure in the setting of cocaine intoxication, we had elevated systolic and diastolic pressures and an elevated heart rate. And using either labetalol or diltiazem lowered these significantly without any adverse events. And then these are the inflammatory markers they looked at, CD40 and IL-4. When you read this paper, they don't really have a hypothesis for why they were checking those to start with. And they don't have a great explanation for why it had this anti-inflammatory effect. It's more likely just a confounding, interesting finding, but nobody has ever followed up on that. But potentially suggestive that there could be some protective effect in the short term. There are also multiple retrospective reviews. So in 2010, the experience at San Francisco General Hospital from 2001 to 2006 was published. There, 331 patients with chest pain and cocaine on their urine tox presented to the emergency department. 46% of those received a beta blocker in the ED. 41% of those patients were discharged long-term on a beta blocker. There was no difference in adverse events, with a significant reduction in the blood pressure in the beta blocker group. Interestingly, there was also a reduction in cardiovascular-related death at a median follow-up of 972 days in those 41% of patients who received a beta blocker at discharge. Around the same time, on the other coast, the Jacobi Medical Center published their experience from 2000 to 2005. There was 348 patients. They must have paid a little bit more attention to their urine toxicologies, as only 60 received beta blockers in their ED. Again, no increase in adverse events associated with beta blockers, but a decreased incidence of myocardial infarction in patients who were started on a beta blocker in the emergency department, 6% versus 26%. Now again, these are retrospective reviews, which have inherent problems with them. One might think, well, maybe the younger, healthier group received the beta blockers in the emergency department. They actually went back and looked at that, and they found that it was, on average, patients who were older and had more comorbidities were the group that were likely to be started on the beta blocker in the San Francisco population. They did not look at that in the New York population. So from this evidence, and there are some case reports that are of a lower quality of evidence that I won't reflect on here, but there's been a sort of meta-review in 2016 and 2017. There are 9 level 1 to 2 studies that would be prospective randomized control or prospective cohort studies, 7 level 3, which would be these retrospective reviews, and then 34 level 4 or 5, which are the case reports, studies of beta blockers in the setting of cocaine ingestion, with 1,744 total subjects, 7 adverse events, and 3 treatment failures. So of those 1,700 patients in this review, only 7 adverse events were from so-called putative cases of unopposed alpha stimulation due to the beta-1, beta-2 blocker propanolol, N equals 3. Beta-1 blocker esmolol, we talked about those 3 events. And then metoprolol, there was one case where somebody had a myocardial infarction reported in a case report. There were no cases were attributed to the use of mixed beta-1, beta-2, alpha-1 blockers, being labetalol or carvedilol. So the authors of this study conclude that mixed beta-1, beta-2, alpha-1 blockers may be used in select patients with tachycardia and hypertension in the setting of acute cocaine-associated chest pain. And one important point of this is to look at the authors of this study. John Richards is an emergency medicine physician, but he contacted Judd Hollander, Richard Lang, and Charles Sand. Those were the primary authors on the initial randomized control trials looking at propanolol and labetalol in 1990 and 1993. And Dr. Sand was the principal investigator on the esmolol trial in 1992. And so it seems that in reviewing the literature, even these people who had published in the 90s on this have sort of the pendulum has swung back for them as well. Again, there are flaws, so-called, with the prosecution here. These are retrospective studies largely. They use urine toxicology, not the identification of acute cocaine intoxication. So your urine tox will be positive 2 to 3 days after the use of cocaine. But in conclusion, intracoronary propanolol following the intranasal cocaine perpetuates drop in coronary blood flow. Systemic labetalol reduces the mean arterial pressure without an effect on coronary resistance or artery restriction. And there have been no reported adverse effects using combined alpha-beta blockers, labetalol or carvedilol. In keeping up with these studies, the American College of Cardiology has actually updated their 2007 guidelines to reflect these studies. So in 2007, it was the level 3C advise against or not enough data to recommend. It is now a class 2B in 2012 that the administration of alpha-beta blocking agents, i.e. labetalol, can be reasonable as long as you're using a vasodilator or a calcium channel blocker within an hour. Yet, the controversy still remains. So our favorite source, Up to Date, Was updated in September of this year. They still say we recommend not using beta blockers prior to elimination of cocaine from the patient's body. And if you really want to go down an internet rabbit hole, you can go to these emergency medicine blogs, Life in the Fast Lane, or The Toxin Hound. John Richards was the author of those reviews. And he talks here about how a dogma is a belief or a set of beliefs that is accepted by members of a group without being questioned. Based on what Dr. Richards has published, I think we can all agree that which side of the beta blocker question he falls on. Dr. LaPointe falls on the other side, thinks it is still absolutely contraindicated to use any beta blockers in this setting. And if you go onto this one, the two authors actually engage each other in the comment section. It gets a little snarky, so if you're looking for some light reading tonight. So with that, the myth, beta blockers are absolutely contraindicated in the setting of cocaine-associated chest pain.
Okay. Anybody have any? There's Dr. Fitzgibbons.
Thanks for the talk. Just a couple of really quick comments. So your comment about retrospective studies with the time to cocaine turning positive. I think the thing to remember is the majority, well, not necessarily the majority, but a lot of these patients are probably smoking crack cocaine habitually, if not daily. And so I think if positive in urine tox screening, presumably they're using, period, and that they may well be actively in their system. But the other thing I was going to say was just, it's a general comment more related to the Mythbusters series. I think it's even more complicated to interpret retrospective reviews when there is a medical myth out there. And you hinted at this, but I think what we have to be careful about with the San Francisco data or the second study is what factors were those clinicians utilizing when they were deciding who to give the beta blocker to. Was it that they were the occasional intranasal user once on a Friday night, never again, and they felt it was safer to give the beta blocker to that person, as opposed to the person who's coming in over and over again, and again, perhaps smoking every single day, but they were more careful not to do it. So I just wanted to make that comment. I welcome your thoughts.
So I would follow up on that. In both those retrospective reviews, they attempted to go back through the chart and ask the question of, in patients who admitted to when their last cocaine use was, and we think that they are acutely intoxicated with cocaine, was there any adverse events in them? They did not find any, but the number was greatly diminished, would not meet statistical significance or be powered to even show that in a retrospective review. And so they reported it as a urine toxicology finding. They did try to do that, but sort of, as you said, it's hard to suss that out, I think. Yeah?
One relevant point, oral labetalol is much more of a beta blocker than IV labetalol. So there's about a 1 to 3 alpha beta in IV and about a 1 to 7 alpha beta in oral. So people that's one reason why you don't see a lot of oral labetalol used chronically for hypertension rather than metoprolol or something else.
Mm-hmm. And I think, and carvedilol is even, is sort of 10 to 1, I believe. And I think that is where it was very interesting when they went through who was started on labetalol, carvedilol. Even in that setting where it's a 10 to 1 difference, they didn't find any adverse events in the patients started on even on carvedilol long term.
Can the people who've been practicing for 20 or 30 years, can they talk about their with their opinion, or has the paradigm shifted?
Yes, that's blue. So what comes to mind is, if not this, then what? So you have a patient who's having chest pain, ST elevation, cocaine intoxication, heart rate and blood pressure is high, and you're a believer that beta blockers, non-selective beta blockers are contraindicated. What do you do? What do they say to do for those people who are non-believers? I think it's quite reasonable to use labetalol with a calcium channel blocker to try to optimize vasodilatation, counteract any potential for unopposed, the alpha effect, and still get some beta blockade. It just seems intuitively okay to do that. But I would be curious to ask, what do you do if you're a believer that beta blockers are contraindicated?
As far as I know, it would be treatment with benzodiazepines and calcium channel blockers would be what they recommended. I don't know if anyone else.
Well, I think it's important that in the two original studies that he talked about where they actually gave them cocaine and then gave intracoronary propranolol versus IV labetalol, they showed no adverse effect in the labetalol study. So I think that clearly using an alpha-beta blocker is safe. And adding a coronary vasodilator, a calcium channel blocker, I think is a reasonable thing to do anyway. In that setting would be totally reasonable to help lower the blood pressure as well as to maximize coronary perfusion, just in case. But I don't know that there really is any great evidence. It looks like there's almost no evidence that labetalol causes a problem. And I agree with Dr. Fitzgibbons, the quality of the studies isn't always great. A lot of them, these are retrospective, some of them. But I thought it was interesting in the retrospective study that 41% of the patients were sent out on beta blockers, and over almost 3 years, they had a lower incidence of MIs. And these are people that are on cocaine, right? These are people that are probably highly addicted. And it was a large number of people. Cocaine is a very addictive drug, and it's very likely those patients, maybe not daily cocaine use, were taking cocaine over that 3-year period. I don't know if they were taking their beta blocker, their labetalol or whatever beta blocker they were put on, but you don't know that. But I thought that was interesting anyway, and might point to potential safety even as an outpatient. Any other comments? All right, well, I think it's time to vote. How many people feel that we should not ever be giving beta blockers to people with acute cocaine toxicity and chest pain? How many think it's plausible that we shouldn't? How many think that it's probably okay, that this myth is busted? All right, looks pretty unanimous.